Cataract always poses a challenge to all of us. And you see, if the pupil is small, it's difficult for everything. Even it's difficult to read what's written there. So similarly, same thing we feel there while doing the cataract surgery. So a small pupil with hard cataract is a typical challenging situation. Now thankfully there are devices we can expand the pupil and do is as routine case normally we used to do with the cataract surgery. So non-dilating or poorly dilating pupil poses a lot of challenges. There is a reduced surgical space because we have to make a small access also in these cases. There is a reduced surgical access, difficult in manipulations, higher chances of trauma to rhexis, capsular bag, anterior capsule, tear, posterior capsule. They may be tear in the posterior capsule, more common in these cases. Iris touch is not uncommon in these cases. And it causes prostaglandin release, thereby further constriction of the pupil. Trauma to iris can lead to chafing, can sphincter tear, there may be iridodialysis, there may be hyphema, there may be PCR. And because of this constricted pupil may have retained cortical matter. One optic of the IOL may be in the sulcus, one may be in the bag. We are not sure where it is because we can't see properly. Increased postoperative inflammation, corneal edema and CME. So what is a small pupil? Basically, what size should be called small? Is it a 2 millimeter? Is it 3 millimeter? Is it 4 millimeter? I think the pupillary small size is related to surgeon's skill. A good surgeon can do even a smaller pupil, but a novice surgeon has to have a very big pupil to do it. And intraoperative situation, what are there? It's a floppy iris, or if there is a posterior synechia, or is there pseudo exfoliation. Then the properties of iris tissue and the pupil. So surgeon's skill and technique if we talk. So first we have to use pharmacological agents like phenylephrine, topicamaride, cyclopentolate, NSAIDs. And if doesn't help, then we can use viscomydriasis. Hilon 5 is particularly good, or we can use soft shell technique. It provides a dilatation up to some extent. Only thing, you have to do repeated filling it, otherwise the effect goes off. Then pupil stretching. If you have to use any device, it's better to use stretching. There are two types of pupil. One is the elastic pupil. They may expand themselves once you stretch them. But rigid pupil may break. They may cause tear, chafing and everything. So before putting any, even iris hook or insertion, any ring, you have to stretch them well. Stretch so that they can be relaxed and there may not be much of the problem for putting pupillary expander in these things. Second, we have to reduce our parameters and we have to use chopping technique more so as to not to go into the periphery, and we have to restrict manipulation to the pupillary center. Bimanual IA is more helpful once you have to remove the peripheral cortex. It's become much easier with the bimanual method. Then coming to the hooks and rings. So hooks are very cheap, easy to use, and only thing they have a lot of problems. I'll not go in details of this, but to start with, you can start with a pupillary hook. Most of these causes some stretching on the pupillary margin. You got a disturbed pupil, and some of the problems sometimes prolapse may be there. Now, fortunately, we have got a lot of pupillary expander. There are new devices which are coming, which are much safe, and in fact, they are getting cheaper also. You can use in these cases. Like this is one. It's a S-shaped pupillary expander. It's like a scissor. You put it and expand it. So we have to make opposite 19 gauge paracentesis placed 90 degree to the main wound. It gives us a good 6 millimeter exposure. So this is a small video. Just look at thoroughly, you'll see how easy it becomes to dilate the pupil. So we make a very small incision, 0.9 millimeter, and these are scissor-like hooks. This can stare the pupil easily, one on this side and second on this side. So you require a little practice, but it can be easily mastered. And you get a nice rectangular area and you can do so your surgery easily. Then manual ring is probably one of the most popular ring available now internationally. It's the latest version is 2.0 that can go through 2 millimeter incision. It's a very thin material, 5.0 propylene. It has got 8-point fixation. We require high viscosity OVD, preferably the Helon 5 in these cases. This, as you can see, is a very smooth one. So you had to grasp one, load it, easy to load. And put it and try to stretch the upper one or the 6 o'clock, whatever you place it. Most of the time the peripheral ones also get one. You are left with the last one to deal with. Stretch it, center it, and you get a nice space to do your cataract surgery. Again, animation. Now we have got another device like eye ring pupil expander. It's a circular soft ring made of polyurethane. You get a nice 6.3 millimeter circular exposure. That's probably the biggest you can get. Again, almost they are similar, only thing their orientation is a little different. This is marketed by BVI. So basically you have to stretch the pupil atraumatically, that's the most important thing. Use plenty of visco, but don't overfill it. That's again an important point. If you put it overfill, then the iris get pressed, then you will find too difficult it. So keep your visco not too much, that makes the insertion much easier. That's a very important tip for this. Almost all the pupillary expander for that matter. And taking it out is again very easy. Just the same injector, you can put it, it will go through a side port. So what we got in India that's very popular, done by our colleague Dr. Suven Bhattacharya, is the BX pupillary expander. It's a flexible hexagonal plastic, that's a polyamide ring. It's just 75 micron thick, very thin profile, and it's a uniplanar in design. It can go through 1 millimeter incision. So that's very easy to put through side port only. And most of the ring you have to put from the main port, but it can be very easily put there. And you have to have a 23 gauge micro forceps with this, and you get a nice 5.5 millimeter exposure. So it's a very simple uniplanar design. We have got 6 flanks, 6 notches, and we have to put alternate one up and down like this. Very flexible. And it's available at the fraction of cost what you could pay for million ring. So you get a nice hexagonal pupil, and you can do all the procedure required, then you can just simply stretch it out. And now you can see we can take it out even from 1 millimeter incision now. So the beauty of these is you hardly traumatize your pupillary margin. Your pupil is normal on the next day. There may be some inflammation, so you have to give some NSAIDs in these cases, you have to remember that. So these are the few benefits: easy insertion and removal, very small incision required, is useful in anterior chamber, there is no clouding there. Hexagonal shape is much more convenient to do. So with this, before ending my talk, I would like to say now we have got the rings from Indian market. RO has come up with the new, that's the injectable one. It's come preloaded. I haven't tried it. Then one is coming from Madhu also, Madhu Instruments. So I haven't tried it, but these are good designs, and probably these are much cheaper also. And they may be main thing, because why we are using iris hooks? Because they are cheap. But now we are getting cheaper rings, which can be used in most of the cases. Thank you very much.
Thank you, Dr. Vinod Arora, for the wonderful presentation of small pupil management with different kind of expanders. A very simple question, like if you have a situation of a small pupil, would you prefer the hooks, iris hooks, or the expanders?
Pardon?
Or the expanders?
Expanders are much better in any condition. In any condition, expanders are much better. They are much least traumatic. They give you regular pupil, and it's much easier to use. Till now, the cost was the only factor. Otherwise, I think they are much better.
Right. Dr. Bhati, you have comment on this?
Actually, looking at surgeons' comfort, their own advantages, their disadvantages of a hook is that you have to make so many ports to put so many hooks, like you're putting 4 or 5, which expander can be done through a port which is already existing. And the other factor is what is damaging the pupillary dilator or constrictor muscles more. So that is also, it depends. The expander is sometimes it is not damaging the iris muscles at all, and that is why the pupil comes back to its normal size, where the hooks may damage the pupillary constrictor muscles, and that can keep the pupil enlarged at a later point in time. But compared to expander, the iris hooks are much easier to use. So if you are wanting a situation where you want to do everything very easily, then the hooks are much easy, and they are easier, and also removal is also pretty easy as compared to the expander. So if you are a surgeon who has got a lot of experience, then I think expander, but otherwise you can start with the pupillary hooks, and then probably later on you can graduate to expander.
Agree, sir. I think for the beginners, I think hook is much easier because it has a learning curve.
Yeah.
Whatever ring you are using, it has a learning curve. Once you are comfortable with hooks, then it becomes much easier to adopt to ring.
Correct. That is what I said.
I think the message is very clear. Once you are starting, it's better to start with hooks. The other advantage is the time taken with the ring is much less. If you have to put a hooks, it takes a lot of times. Not only you make a holes, it takes time also to do with it. So you save on that thing. But it's better to learn first hooks and then switch over to ring. Thank you, sir.
True. Thank you very much. Thank you, Dr. Vinod. So we'll go ahead with the second talk is going to be by Dr. Amit Porwal. Dr. Amit is going to talk on Morgagnian white and intumescent cataract technique to manage Argentinian flag sign. So Dr. Amit, you all know he's the member of AIOS scientific committee as well as ARC. And I've seen this talk given by him quite some time, and it's a beautiful pearls he's going to give to manage the white intumescent cataract.
Thank you, Dr. RP. It's a pleasure to be part of your instruction course. So the topic has already been mentioned. I got no financial disclosures. So Argentinian flag sign was a term coined by Daniel Perón. Basically, it's a peripheral split or radial tear in the anterior lens capsule after the first puncture while doing capsular access in white mature intumescent cataract, whose capsule has been stained with trypan blue. Only when the capsule is stained with trypan blue, the split resembles the Argentinian flag sign, and we call as the Argentinian flag sign. What are the problems we face in this type of cataracts? It's difficulty in visualizing the anterior capsule. The capsule is more stretched. There can be a peripheral split which can lead to the Argentinian flag sign. There can be mid-periphery extension of the capsular axis, and sometimes this liquefied matter which is liberated with my hospital view. So you can see this was an intumescent cataract. I've started with my access, but the initial curve which I wanted, I couldn't get it, so I thought it might extend. So now what I do? I felt that the intraventricular pressure is high, so let me decompress it. So I tried to introduce a cannula and I tried to decompress and see what happens. It's an Argentinian flag sign. Now, if you get this Argentinian flag sign, how you are going to manage it? This is very, very important. So basically, in this there are sharp horizontal edges. So whenever you get this type of sign, you reform the anterior chamber with the cohesive viscoelastic, give a small neck, and with the help of a microrhexis forceps, you convert these sharp horizontal edges into a circular ones. Why this into circular ones? Because the vector forces then will be distributed uniformly over the entire area, and this Argentinian flag sign won't extend posteriorly and cause a PCR. Mind you, you have to refashion the rhexis, both the inferior part and the superior part. Whenever you feel that the AC is becoming shallow, reform the AC with the help of a cohesive visco, and with the help of a microrhexis or a microvanas with both right hand and left hand to be used, and you can convert these sharp horizontal edges into the semicircular one. Well enough that when you put the IOL, there should be enough coverage of the optic of the anterior capsule over the optic of the IOL. Another option is basically you can convert into a can opener capsulotomy. When you convert into can opener capsulotomy, never proceed with your phaco. Always make sure that you convert into a manual small incision cataract surgery and finish your surgery. Sometimes what happens, this is an intermission cataract, you have got the initial tear, you are doing the rhexis, and because of AC becoming shallow, sometimes the rhexis get extended in the mid periphery. If you get this, stop then and there, reform the AC, and from the opposite side of the rhexis where you are not extended, you give a small nick with the help of a vanas, and then reform the AC, and then with the help of a rhexis forceps or a microrhexis forceps, whatever you are comfortable with, and depending on the size of the wound, you refashion the rhexis from the other side. So this is the way you are going to handle it. Now, if you are proceeding with phaco in this type of cataracts, what are you going to do? You have the Argentinian flag sign, and most of the time these cataracts are soft and fluffy. You have to make sure that the irrigation port of the sleeve, they don't direct on the split end of the anterior capsule, because if these jets fall on that area, then this rhexis might extend posteriorly and might cause a PCR. Whatever is your preferred technique of phacoemulsification, whether it's a direct chop, stop and chop, continue with that, but just make sure that your parameters are lowered down. You do a slow motion phacoemulsification, and most of the time with simple aspiration and a bit of phaco energy, you can emulsify the whole of cataract. And then once you put the IOL, then if you think that the optic coverage is more, you can refashion the rhexis. But only the important point is that you should always make sure that you do a slow motion phacoemulsification. Now, coming to the main thing, we don't want this complication to occur. So what are the techniques which we can do to avoid this Argentinian flag sign? This is all we want. So what is described in the literature is a mini rhexis, a snail pattern or the onion pattern rhexis, a heart-shaped rhexis, or the Dr. Mohan Rajan's technique, which is pancho rhexis. But what I recommend is, basically you can see in this is a mature intumescent cataract. So always staining of the capsule with trypan blue is a must. Why? Because this elastic capsule becomes more brittle when you stain the capsule with trypan blue. Cohesive viscoelastic is injected, and on a 260 syringe, a 24 gauge needle is mounted and pierced into the center of the anterior capsule. Only the bevel is pierced, and you stay there and aspirate, and you saw that the central part got decompressed, and whatever was convex has now become flat or concave. Once you have done that with the help of a capsulotomy needle or a microrhexis, whichever instrument you are comfortable with, make sure that the AC is always formed and try to start the rhexis. Always begin with a small rhexis, and once you have reached the initial prick point, you can go beyond that, and now you are doing it snail pattern or onion ring pattern rhexis. So I always prefer to make sure that we have a smaller rhexis, not mini rhexis, a smaller rhexis, because that gives more comfort and the chances of tear is very less. Once this rhexis is done, you can emulsify the cataract, inject the IOL, and if you think that the rhexis is too small, you can refashion with the help of a microrhexis and microvanas. Quite a few times we get a decentered rhexis. So I have given a small nick with the help of a microvanas, and through a microrhexis forceps now I am refashioning the rhexis so that I have a circular central opening and a well covered anterior lens capsule over the optic. So doing a small rhexis and then converting always helps. You can see another case. A 2cc syringe is injected, pierced into the center of the anterior capsule, straight there, only the bevel down, and you saw the concavity which occurred when you are aspirating it. We did a study, we compared with 5 ml, 2 ml, 26 gauge needle, 24 gauge needle, and we found that the 24 gauge needle is adequate size. Now in this the tear was in a different direction, so you should be smart enough to understand whether you are going to start your rhexis from the right hand or the left hand or the right side port or the left side port. So here I started with the left side port with the help of a capsulotomy needle, and in between I felt when the ergonomics of my wrist is not helping me, I changed the direction, and then from the other side port I started completing the rhexis, and you can see how nicely the rhexis is completed. Another way of tackling is doing an anti-yak capsulotomy. A single shot of 1.2 millijoules in the center of the cataract is given with the anti-yak laser. And once you pierce it, there's a gush of fluid. You shift the patient to the OR. By that time, the whole interventricular pressure bag is decompressed. And what you get in the OT is after you stain the capsule, you get a striate color opening. You can see in this, there's a gush of fluid like a waterfall. You can see one shot, yeah, and there's a gush of fluid falling down. So it's like a Niagara fall, everything is falling down and nicely it gets decompressed. So how the capsule looks after you've done a yak capsulotomy, it is a striate pattern opening. So with this striate pattern opening, with the help of a micro axis forceps, you can start your axis and you'll be very comfortable. The AC depth increases after this yak capsulotomy. That means it was an intumescent cataract and the AC depth has increased. We did a study in which we enrolled 52 eyes of 52 patients and we compared preoperative anti-yak anterior capsulotomy and said that it is a safe and effective technique in reducing intraventricular pressure and avoiding intraoperative complications in mature intumescent cataract. We published this in Asia Pacific Journal of Ophthalmology and was also featured in the AO Academic Express. We did one more study in which 100 eyes of 100 patients were recruited. In group 1, preoperative anti-yak capsulotomy was performed. In group 2, intraoperative 24 gauge needle decompression was done. And the outcome was basically lens decompression needs to be repeated, is an ideal technique to manage these cataracts. Lens decompression technique reduces the need for repeated entry of instruments in the anterior chamber. A perfect central opening is achieved in a single opening and there is no complication rate at all. And this one the best physical posture also. So my tip for managing this mature intumescent cataract is intraventricular decompression by whatever method you are comfortable with, go ahead. So there are two options which I described and which I published. One is anti-yak laser capsulotomy and second one is slow and guarded decompression with a 24 gauge needle. So this is the most important tip to manage these Morganian intumescent cataracts. Thank you.
Thank you very much for your wonderful presentation, how to manage these intumescent soft cataracts. The important point when you are dealing with these intumescent cataract, because your idea is to decompress the back, your capsule has to be flattened before you start the capsular axis. So you have several techniques for that, as Dr. Amit has shown the beautiful techniques. And once you decompress, then the chances of extension becomes very low. So before you start the capsular axis, always decompress, and the decompression has to be done complete before you start the capsular axis. So that is very important point. Doctor,
Yes.
you want?
So, what was the power, and how the size was you measured that the?
No, the yak machine has a power setting. So we use an upper yak laser. Upper yak laser, it is 1.2 millijoules for Mark II. So you keep the setting on Mark II and give one shot in the center. That's it.
One shot.
So one shot, it gives enough good opening. And when this laser shots, it's like a flower petal. So there are multiple flower petals opening and there's a gush of fluid. And this never extend because the moment the energy is the shot is given, the whole thing falls down like a waterfall. So we didn't have a single extension of this axis. And it is something different. With laser, we get a striate pattern, and with Dr. RP introduced the sewing needle technique. That needle is round, so that when you pierce it, only thing is what I used it and I felt that you need to apply some pressure to pierce it. Otherwise, once you pierce it, the hole is totally round like a punched out hole. So anything, whatever technique works should be used. Main thing should be intraventricular decompression.
Please, any comments?
So I can show you a 30-second video of mine. I use a retractor axis instead of puncture axis, where I use a retractor tip and maybe 3 or 4 cuts with a 600 vacuum, which is pretty high. As soon as you cut, the tip of the vitrectome enters the lens and the whole liquid cortex is sucked in 5 seconds. So it becomes concave immediately. So initially I did yak anterior capsulotomy, capsule puncture also, yak puncture, and everything I have done, but most recently I have started doing vitrectomy, using vitrectomy to puncture and to aspirate the cortex, and that is something, again, it's one of the variants of what Dr. Amit has told. So whichever way you want to do, you have to puncture and aspirate to debulk the cortex so that the anterior capsule becomes concave and there is no enhancement or increase in the size of the puncture. That is the ultimate thing.
Problem comes up when you do not have any fluid in the interlenticular space. It's just the swollen cortical material. It's swollen cortical material. So there, the puncturing or aspiration won't work. So what do you do in these cases?
See, if the vitrectomy probe is there, it cuts and sucks both. So even if there is hardly a little lesser fluid, it will cut whatever is there, it will cut and aspirate both together. So this works in every kind of, bulging nucleus where there is a turgid fluid inside and there is a intralenticular pressure which is higher. So it works very well in all my cases.
That's good, yeah. Thank you very much. Thank you. Yes.
Sir. Yes.
Stretched.
Yes. Yeah.
No, it won't happen in the calcified, but generally what happens, it's a swollen cortical material or swollen nucleus also, like we see normally with the phacomorphic glaucoma. In phacomorphic glaucoma, you don't have fluid, it's the swollen, the whole lens material swells up, even the nucleus becomes very voluminous. And there, puncturing won't work. So, there are several techniques, Dr. Amit will let us know. One of the, you do the anterior vitrectomy also before you start the capsular axis, just to decompress the whole pressure which is developing in the interlenticular space. So you do the vitrectomy, so the whole thing goes back, and then you can start the capsular axis. And the idea is you have to, if you are able to decompress, then it's fine. If you are not able to decompress, then you have to make a microraxis because double raxis or microraxis, because you have to make a central small hole actually in the lens so that the hole will not extend. So we do the microraxis, small raxis, or my technique which is called the sieving natal microcrystallotomy. So these techniques work then very well. Yeah. So thank you very much. Thank you, Amit. And we'll go ahead with the next talk is by Dr. Arvind Kumar. Dr. Arvind is, he's a professor of BV Nagar in Hyderabad. And he's going to talk on a technique called terminal chop, new technique to manage the rock hard cataract. So he's going to talk about the rock hard cataract. And Dr. Arvind has worked a lot, and he has published a lot of papers, and recently also, because I've just seen him last 1 or 2 months only, he has published 12 papers. So he's one of the machine of publishing the papers, and all beautiful papers, and he's coming out with a lot of studies comparing, and so he has published on this technique also 2-3 papers, which has been accepted in international journals also. Dr. Bharti sir, you said that vitrectoraxis, there is a technique from Dr. Mohan Rajan which is called as the panchoraxis. Do you find any difference in these two?
In panchoraxis, there is a phaco tip which he introduces into the antechamber, puts the opening on the antecapsule, and starts, vacuum with power. Actually, the phaco tip is not meant to puncture the antecapsule. It is only, it's like pushing the needle to puncture and then suck. Whereas the vitrectomy thing is actually meant to cut. So as soon as it sucks in a little bit of, antecapsule, it immediately cuts because the cutter is going on at a higher rate.
Right.
So I find that that is what I said. I can show you if there is a time, I can
yeah.
show the video, which is hardly 30 seconds.
Yeah, we'll see that video.
Yeah,
definitely.
we'll see yes. Yeah, whereas this is,
So I think this
Yeah.
vitrectomo cutter is more safer than the
correct.
The
And it
phaco needle.
immediately sucks in the, yeah. No, there is no need to have a circular. Even yak capsulotomy is not circular. So it is a stellate cutting. It's not even it's a flap kind of thing.
Yeah.
It creates a flap which you can rotate.
right. The difference between the two. yeah.
I'll show you the video, then you
Difference
can
between
decide.
the two.
Yeah.
All right, thank you. Dr. Arvind, go ahead, please.
Good afternoon, respected chairpersons and my dear friends. Thank you, AIOS and Dr. RP sir, for giving me the opportunity. So I will be speaking on rock hard cataract, what technique. So I will be discussing in detail regarding the new technique innovated by our own terminator, Dr. Rajendra Prasad sir, that is terminal chop. So there are many challenges when we are dealing with the rock hard cataract, because there is very high phaco energy is to be required, and these hard leathery nucleus, they are difficult to create a full thickness crack, the first initial crack to divide into two heminuclei, and there are more chances of endothelial burn. There are stress on the granules leading to jonular dialysis and nucleus drop, increased chances of wound burn, and of course posterior capsular rent, and it is very stressful for the operating surgeon and staff also. So we need to look at the Griffith's theory of brittle fracture. So it's a very lean and thin man. He is working on the hard rocks. So he is using the blunt forces at the equator, at the most weakest part of this rock hard. So you can see this is how a lean and thin person able to create a crack, full thickness crack, by using the blunt forces. So this is theory of Griffith's brittle fracture. And now you can see it is divided into two quite easily. So this is a newer technique for nuclear fragmentation introduced and invented by Dr. Rajendra Prasad. It is suitable for medium to hard grade of cataract, and it reduces the surgical time and also the chances of complication. This technique was first published in IGO in year 2016, and we are practicing this technique since 2013 when Dr. Prasad first described the same in a conference. So we have operated over 5,500 cases using this technique. So how this surgical technique is different from the direct chop technique, the direct vertical and the horizontal chop technique. So first we need to have a very good rhexis, then a short superficial central trench of 1 into 1 into 1 millimeter size is created to hold and engage the phaco tip. Then the phaco settings are changed to higher vacuum settings from 450 to 500 millimeter of Hg with 50 to 80% power and 30 to 35 millimeter per minute of AFR. Then the phaco tip is engaged at the distal end of the trench. Then phaco probe is impaled superficially, only superficially, keeping the tip directed towards the equator, parallel to the pupillary plane, not inside, to achieve firm hold of the nucleus just within the equator. Then the equator is drawn within the capsulotomy edge, and under direct visualization, a wedge-shaped blunt olive tip chopper, that is a terminator, is simply passed around the lens equator. Then it is dragged 1.5 to 2 millimeter through the open edge equator to create a small groove. So this dragging generates tension and dispersive forces along the sides of the groove, consonant to drag pick in rock excavation system, and initiates a full thickness nuclear crack. And this full thickness crack traverses automatically across the lens to the other end of the equator and divides the nucleus into two equal halves. So this is the terminator chopper. So it creates a shallow groove with a specially designed chopper and keep the chopper in a lateral position. With both the chopper and the phaco probe, a splitting force at 90 degree is generated, and this is propagated from the equator to center and equator on the other side. The force is working along the brittle lines, and inside out dispersive mechanical forces are used to create the crack. This is how it is done. So it is only a superficial impalement, as you can see in this picture. Now I will show you some videos. So it's a cataracta nigra, as you can see. So this is the specially designed terminator chopper, blunt olive tip, so there is no chance of PCR or posterior capsule damage. So this is how it looks. Right? So at high power and vacuum setting, superficial impalement towards the equator of the phaco probe. Then this terminator chopper goes behind the equator. So all the actions are parallel to the iris plane, pupillary plane. So it is divided full thickness, a little bit softer cataract, only superficial impalement. The terminator chopper goes behind, and you can see very easily into two heminuclei without any fuss. So how it is different from the other techniques? So in the terminal chop, the instrument tips, they move away from each other at the equator, and there is only superficial impalement of the phaco probe and chopper parallel to the iris plane. Whereas in the horizontal chop, the instrument tip move towards each other in horizontal plane at the equator, and the phaco probe deeply and towards the optic disc. In the vertical chop, the instrument tip move towards each other in the vertical plane, and the chopper direction is towards the optic nerve. So in terminal chop, it propagates the initial crack into a full thickness fracture in low compressive stress. In horizontal chop, it creates a stressful compressive force, and whereas in vertical chop, there is a plane shearing force with very high stress. So we've published a retrospective study of around 750 cases, also accepted at the ESCRS. So myth versus reality. Some says that it is a blind procedure, but we are doing all the steps and the direct visualization. Some says there are more chances of PCR, but it is comparable. Some says there is more chance of endothelial cell loss and post-op edema. It is comparable or less. So we did the first CTRI ICMR project. We compared this terminal chop technique with the stop and chop and direct chop. So these were already published in IGO. So this is the world first such randomized control trial. So these RCTs are the higher evidence to prove any hypothesis. So now coming to the average cumulative dissipation of energy. As we see in the nuclear sclerosis grade 2, there is no significant p-value difference, although it is slightly lesser in terminal chop, 6.48 as compared to 7.85 in the direct chop and 6.9 in the stop and chop technique. But when the nucleus becomes harder, nucleus grade 3 and 4, you can see this terminal chop technique has a significant p-value as compared to stop and chop and direct chop technique. And there is also lesser ultrasonic time. Thank you so very much.
Excellent talk, and I think without a doubt the Terminator has become the way to go for any kind of cataract, soft, hard, medium, whatever. And you have already mastered the technique, so you are teacher of teachers, so there is no doubt that you can
a
show
lot to
all
learn
these
from both of you, sir. I'm always a
but
student.
The inventor of Terminator is sitting here. So we are privileged to have him as the main chief instructor of this show. So this is actually amazing invention, I must say, and you have showed it to the perfection. Thank you, Dr. Arvind.
Thank you, sir. Thank you so very much.
And next is our chief instructor, Dr. Rajendra Prasad. He will be talking on T-Soft, the new technique to manage sticky, soft and glued cataract.
Good evening, and thank you, Dr. Bharti sir, for the nice words and for being here with all of us in this beautiful evening. And this subject which I am going to talk about is soft cataracts. And you know that these soft cataracts, we all have started coming across more and more in our surgical practice. The reason you all know that it's basically the patient's requirement, and we have already finished these hard cataract now. That is the reason, like, we have to be now into the soft cataract, and we have to learn how to manage these soft cataracts. Okay. So the biggest problem we come across while dealing with the soft cataract is it's like a glued kind of material and sticky material. So what you have to, what we come across, the problem is like you can't hold the nucleus and you are not able to rotate it properly. And while splitting, like you are not able to crack because it's very soft, you can't crack them. So you cannot separate or split the nucleus into segments, and if you are not able to segment the nucleus, then you tend to use the second instrument more and more and trying to bring that soft material towards the phaco probe. Now this becomes very risky because many times, because if you are holding this like this, so going very close to the posterior capsule, and since the material is very soft, there are always the chances of this phaco probe hitting the posterior capsule. This is what happens. The one of the complications we may come across with the soft cataract. And if you hit the posterior capsule, because this is another soft cataract, as you can see, because you try to hold the cataractous complex, because you don't have very hard nucleus. It's just the cataract cortex, epinucleus, and nucleus all combined. It forms a complex, and it hits the posterior capsule, and you get into the problem, the posterior capsular rupture. As you can see here, now there is a complete opening of the PC. So what you need to do with these soft cataract is, the first important thing with the soft cataract is your hydro procedure in the capsular axis has to be perfect. So do a good capsular axis, never do a capsular axis thinking that it's a soft cataract, you should not land up with the small axis. Try to do a little larger axis of around 5.5 to 6 millimeter, because the larger the axis, you'll be much better, you'll be managing the soft cataract. And creating a rhexis again in a soft cataract is always a challenge. So your vector forces has to be accurate so that you don't get into the extension of the capsular axis margin. So make a capsular axis of around 5 to 5.5 millimeter, like I'm doing here in this video. And once you complete the rhexis, then the second step which comes up is very important, the hydro procedure. As you can see, I'm using a hydro cannula, and see the wave which is going underneath. So this is what is required, because you have to do a complete cortical cleaving hydrodissection. If you do not do the cortical cleaving hydrodissection, because generally, as I said, the cortical material is stuck to the capsular bag. So while doing the aspiration, while doing the manipulation in the center, you have to use more of second instrument, and then the complications may arise. And look at the type of the needle you have to use for the hydrodissection. It should be a flat needle, because there are fluid wave. If you want to create a complete cortical cleaving hydrodissection, your fluid has to go, it has to spread when you inject. Don't just leave the needle at the capsular axis margin. Go little inside, at least 2 millimeter inside, towards the equator. Don't inject at the margin, what we do in the hard cataract, but in the soft cataract, don't inject at the margin, go little inside and inject fluid at the equator. If you do that, then you get a good wave of capsular axis, and you get a complete capsular axis in these cases. So once you do the complete capsular axis, you have a lot of techniques available now. Several techniques. We are all practicing many of these techniques. But the important point which I'll show you here is, because if you come across a very soft cataract, like in a pediatric cataract or very early age cataract, these are absolutely soft cataract. So in a pediatric age group cataract, as you can see here this video, because I'm doing a side port, it's complete, always stain the capsule. It's very important, because otherwise you lose the capsular axis margin. Stain and start from the center. As you can see, you have to stretch it more. So if you try to stretch it more, then there are always chances of extension. So keep your central forces towards the center and go very slowly. And now you can see I've completed the rhexis. Now material is not much. It's just the fluffy material and a little bit of hardened material at the center, but you can use just the coaxial aspiration or the bimanual aspiration technique only. You can aspirate the whole material out of the capsular bag. Now once you complete this, and if you are dealing with the pediatric cataract of less than 5 years of age, always do a PCC. So what I'm doing here, I'm trying to do a PCC again. So PCC again doing is very important, because, and it's must in these cases, otherwise you'll end up with the capsular opacity, and then YAG laser doing in these small kids is very difficult. So do a good PCC, as you can see here. And once you do the PCC, if the child is less than 3.5 years old, must do an anterior vitrectomy. Otherwise, you'll land up with the vitreous membrane formation. That is another problem. So inject the IOL into the bag. So always make sure that your IOL is going into the bag, not on the anterior capsule or in the sulcus. So this is how you can complete the surgery in these pediatric cases. Always put a suture. So another important point, because the sclera is very elastic, so opening the healing or sealing is not possible. So always put a stitch. Now if you get a soft cataract which has a bit of firmness in the nucleus, then the best way to do is, this is called as a visco-flap technique. Visco-flap technique means you are injecting viscoelastic to completely dislodge the whole cataractous material out of the capsular bag. This is very simple technique. Just go underneath the capsular bag and inject a good amount of the viscoelastic. Now once the whole complex is out of the bag, you don't have to struggle. You can very simply go inside with the phaco probe and start aspirating the whole material. This is how you can complete the whole surgery with a single shot and aspiration of the whole complex material. But many times you come across these acquired soft cataract, which are a little more sticky and more glued kind of thing. So in these cases, the best way to, after completion of the rhexis and all and hydrodissection, do a stop and chop technique. But important point in doing the stop and chop technique in these cases is like your phaco probe, look at the direction of the phaco probe. It has to be parallel of the surface of the nucleus. Don't keep it vertical like we do in the hard cataract. In hard cataract, we make a trench vertically, like you go deeper. Here you don't have to go deeper. You can just split the nucleus into two, rotate it. Now you have a two heminuclei, and then taking out these heminuclei becomes very easy, because if you are able to completely separate the two heminuclei, as you can see here, then the heminuclei will automatically come on the phaco probe and you can completely start aspiration. This is how you complete the first heminuclei and rotate it and take out the second heminuclei, and you can complete the surgery. And it's so simple. But you have to split the nucleus. So splitting is very, very important in these cases. If you are able to split, then you can come out. And then comes this soft senile cataract. These are the little more difficult soft cataract, because you have a little more firmness and more glueness. So in these cases, a simple technique which I called as a T-soft. T-soft means you are using a splitter. It's not a chopper, you are splitting the nucleus. See, as you can see here, because just hold the nucleus, it's very low vacuum and without any phaco power, hold it and split it. So if you are able to split, because the splitting of these soft cataract is very important, because if you are able to split, then the whole process becomes very easy, because you are not able to split. Then you start making, because you get into the problem of Swiss cheesing and Swiss wire cutting of the nucleus, because the sharp choppers won't work. So you split the nucleus into multiple fragments or two fragments, then you can completely complete the surgical procedure and finish off the aspiration or emulsification of these softer material. And as you can see here, because I'm doing the completion of the aspiration, and this is how you complete. And once you complete, then you can go ahead with the intraocular lens implantation. Another important point is like polishing is very important. In these soft cataract, because there are immature cells which is lying in the fornices and on the posterior capsule. So you do a good polishing of the capsular bag, like anterior as well as the posterior capsule, and then inject the IOL into the bag and you complete the surgery. Then comes up the little complex soft cataract. This is the soft posterior polar cataract, as you can see here, because you have a good posterior polar cataract which is seen after doing the minimal hydrodissection, which I call as a peripheral hydrodissection, not the central one. You split the nucleus into two. Again, I'm trying to split, and without rotating, just bring these pieces on the phaco probe and you inject viscoelastic, a good amount of the viscoelastic before you take out the phaco probe. And then with the bimanual technique, you can do a very simple aspiration of the cortical and the epinuclear material, and without tackling. But in this particular case, as you can see now, we have a PCR, a big PCR, which is a radial PCR, which has happened. This was pre-existing PCR already there. And now if you have a PCR, then don't worry, like you have to just because generally because in these cases you don't get the vitreous prolapse because vitreous piece is always intact because the pre-existing PCRs. And I'm going ahead with the single piece IL implantation. The important point is that leading haptic, if you are able to put in the bag is the best, but otherwise you can keep it on the anterior capsule. And then once you keep it on the anterior capsule and with one by one, a nudging technique, which is called as the haptic nudging technique into the capsular bag, inject good amount of the viscoelastic, and with the dialer, then you can just hold one of the haptic and put it into the bag. Now this is how the one of the haptic has gone into the bag, and similarly the second haptic, you can just slightly dial or nudge it into the bag. So this is how you complete this, and the remaining some amount of the cortical material which you can completely aspirate later on. This is how you complete the surgery. And as you can see, there is no vitreous, so you complete the surgery. So to conclude, the soft cataracts, the important point in soft cataract is because you have to use very low parameter of the phaco. Always split the nucleus into two segments so that better aspiration of the nuclear material, and use the technique which is more comfortable with you. Thank you. Thank you very much.
Excellent talk, Dr. Rajendra Prasad. It gives us an idea as to how to manage these soft cataracts and divide and chop them. I will invite Dr. Satanshu for his talk on posterior polar cataract, how to prevent posterior capsular disruption.
Thank you, sir. RP has very elaborately described the soft cataract management. When cataract is a very soft supracapsular or bringing the cataract into the antechamber, in the pupil plane, and then remove it is a good thing. But cataract is grade 1, that you have, whenever you are making a tunnel, you should keep reducing the power of the power, so that when it start in place of cutting, it start grabbing or it can start holding the nucleus. That is the exact power, and then you can cut any type of nucleus in soft cataract. So there is no issue of cutting or dividing a nucleus in soft cataract. So posterior polar cataract always poses a threat to any cataract surgeon. But if we follow simple tips, we can achieve a 100% success rate without any doubt. So what are the tips? First important tip is the First important tip is the careful preoperative average slit lamp examination of the patient. So if you are already decided in mind, this is the simple slit examination, vertical groove, where you can see the wall-like appearance, or we can see it is a slit-like, we can onion-like appearance, onion ring, bullseye. So we can definitely keep in mind that we are going to deal with a different type of cataract. We have to get preparation done in our OT. On the sides we are showing this is a PC thin area, or you can see suspected PC rent there, because 33% cases of posterior polar cataract, chances of PC rent are there. So whenever we do hydrodissection, the fluid comes in this way and it come in this way. This is the nucleus. Fluid go behind the nucleus in this way to the weakened portion of the posterior capsule, and this cause increase in the rent and nucleus drop. The rent will increase and there is a nucleus drop. So we have to be very careful. We should not do hydrodissection at all. There are many techniques. I can show you 3 or 4 techniques where we can remove the posterior cataract without any hydrodissection. So you should know this is the area behind, other than the posterior capsular area. This is posterior subcapsular area. This is posterior subcapsular area. This is the onion. This is the posterior polar cataract area. So other than posterior polar, there is a posterior subcapsular area. So you should not get confused. This is the case for posterior polar cataract where we make an incision. We have to do bimanual, so we made 3 port in this case. Normally we do not do bimanual in every case. Dye is very important even if it's a soft cataract, because you have to not to lose the cut end of the capsular axis at any cost. procedure are same. Capsulolysis, important thing is that tip number 2, we should have a sufficient adequate capsulolysis, neither too big, neither too small. We have to keep the size small because we have to put sometime IOL in the sulcus over this capsule because chances of precedent are there. The capsulolysis is oval shape we are making. My friend from research, Charanjit Singh, is a very advocate of this capsulolysis of oval shape. Advantage of oval shape capsulolysis is that easy maneuverability of the nucleus, not much manipulation, and sub-incisional epinucleus and cottage removal is very easy in such cases. Now we have made a tunnel. So you see, this is soft catheter, we have made a small tunnel. Because we have more space now available because capsulolysis is oval shape. So we have more space now available to go up to the capsular margin. So more space we have available now. Now do see, we have not done hydrodissection. There are two ends of this tunnel, and here we are injecting the fluid to do hydrodelination. Hydrodelination is very good because all the fluid you are injecting is going in the nuclear space. This is not going behind the nucleus. Because we are putting inside, we are opening the door, and inside the door we are injecting the fluid on both the sides. So there is no chance of going fluid behind the nucleus. So posterior capsule end will not get increased. So this is the ring. We can get even the ring like this by the hydrodilation. So no hydrodilation, good hydrodilation. If you require, you can do hydrodilation from other port also. Now we are pulling the nuclear part piecemeal from the sides below the axis and trying to physically elevate the nuclear part because these are soft catheter. We are trying to elevate the the posterior polar part and trying to engulf it by the phaco. Central part we have left behind because there is a rent, we can doubt the rent there, we have left there. So pulling from the side, and now see, everything has removed and there is no dent there, so we are happy. But before removing the main ports, say from the phaco probe, we have to inject the viscoelastic not to allow the chamber to collapse. This is tip number 3. And then we do bimanual aspiration to pull out the nucleus out, cortical matter, because we don't want to lose the chamber stability any time. It will increase the rent if there, or it will produce the rent. So gradually we are removing. Once removed, then again inject viscoelastic before removing the port from other side and do the bimanual from other side. So it is a slow process. You should keep your cool. If you do phaco normally 5 minutes, do it in 10 minutes. So clear all the cortical matter, and once the cortical matter is clean, and then you find the posterior is good, then you can do implantation. So if you follow simple tips, then you can achieve 100% success rate in such type of lenses. You can put. So posterior polar is your mindset that you should not get afraid of it, but you should be ready for the vitrectomy. At least anterior vitrectomy should be known to all anterior segment surgeon, and they should do it. Cleaning has been done. If there posterior capsule, there are some, you can see some part on the posterior capsule, but we are not going to clean this part because it gives risk that posterior capsule can rupture there. You can see center there is some posterior dirty. We can get it care later on by the laser. So whenever you injecting fluid also, you should keep these are tips. Correct preoperative diagnosis, small but adequate access, no hydrodissection, gentle hydrodilation. एक मिनट पीछे करना, एक मिनट बैक करना भी, नहीं बस लास्ट और लास्ट, आगे बढ़ो आगे बस. No nucleus rotation, AC should be maintained all the time, parameter should be low, phaco power we are using more hardly, एक मिनट फिर वापस. Phaco power you are using is 30 only, bottle height is 50-60 centimeter only, and vacuum and flow rate is 20-30 only. No panic. If there is a complication, manage complication efficiently. You should not panic in the OT when there is a PCR because you are already expecting something wrong can go wrong. Thank you.
Thank you very much, Dr. Sutanshu, for the wonderful deliberation on posterior polar cataract. Beautiful videos and wonderful technique you have used. You said you will not do the hydrodissection in any of these cases, and but there are reports and the publication, they say like multi-directional or multi-point hydrodissection could be of use in some cases. So what do you say that?
When we can get the best result without the hydrosession, we should not take the risk. There one more technique that we had started doing now. It is one of my friend from Brazil, Dr. Neto is doing. That we are mechanically separating the. I will can show the video next time. Mechanically separating the nucleus. We are not doing hydro. We are not doing hydrodissection. And nucleus rotating like a spin like this. So next time we'll include that video also in my presentation. I am just recording it nowadays. So there we have very good methods to. Why should we take risks of the hydrodissection? Fluid can
chopper?
go.
You have that chopper? That's
Yeah, I got chopper.
Okay.
I got it made here. It can be really
It's available where?
available very soon in the market.
okay. Soon in the market.
Yeah, market
Okay.
soon in the market. So there is one more this hydro camera is developed by Dr. Bhumi from the Calcutta itself, from Disha. He has got port not on the tip but on the side. So
Right,
when you do
right.
hydrodissection, fluid never goes behind the nucleus.
Right,
That
right.
I also tried this. I have a video also of this. Next time I will show the video of hydrodissection in posterior polar catheter because that is a more important thing.
That's good.
Fluid go from the side. That's the go on the tip, not behind the nucleus.
Not behind, yeah. That's nice.
That is another good technique of the hydrodissection.
Yeah, yeah. Thank you very much. Thank you. So our last talk is Dr. S. Bharati. Dr. Bharati is the CEO of Bharati Eye Hospitals in Delhi. He is one of the most wonderful cataract surgeons in the country, and we call him the Dronacharya of cataract surgery and the refractive surgery also. So Dr. Bharati is going to talk on suture ring fixation and the technique to manage subluxated cataract. Dr.
I'll
Bharati.
just show you this 30 seconds video.
Yeah, sure.
So this is how we do a vitrectorexis. Go ahead, put the vitreous probe inside, start suction and cut. And that you continue to suck and see how the whole capsule.
So what are the parameters, sir? You are doing it so.
This parameter is 600 vacuum and almost I would say about 100 to 400 cuts. It's simple, normal anti-vitrectomy settings. There is no change in the settings for this. And you can see the whole thing has become, I've taken the vitrectomy cutter out. There is no extension. One more tip I wanted to give, in a very soft cataract, we can always do once you have done a rexis, instead of doing any hydrodissection, hydrodilation, whatever, you can put viscoelastic. So if you put viscoelastic, the whole, the AC should be shallow. You should drain whatever you have put in the antechamber and then go with the viscoelastic and put a viscoelastic behind the rexis. It goes behind the nucleus and pushes itself, the nucleus out, and you can take it out very comfortably. It will not rupture. So that is okay. So now I have to find out what is the subluxated where is my subluxated cataract, and there are a couple of videos for subluxated cataract. So I am showing you one of those subluxated cataract with mydriasis, and let's see how I manage it. It is a subluxated cataract, and the initial things are very comfortable and easy. There is no problem. You can go ahead and do the rexis very peacefully. This is actually, today if I have a subluxated cataract, I would do a flax, do a femtolaser anterior capsulotomy, and this is a new a capsular hook and a iris hook combined in one. So this is a very good tool in your hands. You can put one into the capsule and other onto the iris. So once you have put both of them, then the pupil will also remain dilated and even if there is a subluxation, the whole thing will not do, go back. So this is one thing which is, and it is available from our own Gupta ji. Gupta, yeah. So this is very easy to find, and there is no problem in that. So you can start doing, once you have found that this subluxation is taken care of, you can do whatever you want. You can do chopping, you can do division, whichever way you want to handle this kind of case. It's not very difficult, and you can manage it. This is one case, and the other thing I think we wanted to show was the suture ring fixation. This is much easier, and uh, I think anybody can do it. There is nothing great about it. So I'll stop it here, and let me find out. Okay. This battery is gone. My own battery is also bad. Power bank needs to charge that.
पावर बैंक लग जाएगा.
So this is one case of subluxated cataract, which is nearly 270 degrees subluxation. As you can see from here to here, there is a large subluxation with a lot big zonular defect, and I have already made a flap, scleral flap, so that if I want to do a Sioni ring, and as you can see when I am doing the rexes, the whole lens complex is moving, and I have to be very careful that I am able to do this rexes with a very peaceful way, and then I do a hydrodissection, because without a hydrodissection you cannot put a Sioni ring. So, and to hold the rexes, I want to put a iris hook, since at that point in time the capsular hooks were not available with me. I was kind of using iris hooks for all these cases, and as you can see, once you have put the iris hook, there is no problem. All this cataract was pretty kind of soft. If you have done a good hydrodissection, you can do in a IA mode also, you can do this. Now I have to put a Sioni ring, and once I want to do a Sioni ring, I have to put a 26 gauge needle on one side, and then take the other end of the suture out, and then a segment. It's not a complete ring, but it's only a segment. At this point in time, the iris hook is out and sitting comfortably. There is nothing I want to do with that. And once I have done that, okay, not a Siani segment, it is a complete ring. So I have to put this and gradually slide it in the capsular bag. Once I have done it in the capsular bag, I want to tighten the suture on the sclera so that the whole capsule and capsular bag is completely stabilized. And if you have only one suture, then you can use the same needle and tighten it and do a knot on one suture itself. There is no problem. Once you have done that, you can stabilize this thing very comfortably, and after that, if you think that everything is stabilized, you may continue with your phacoemulsification and do the implantation. And then take the cortical matter out with irrigation and aspiration. And as you can see, because of the iris hook, the pupil was slightly peaked, but now that is all gone. There is no vitreous in the antechamber, and there is not much of an issue with that. And you can put the pupil back and put the IOL. So this is one way of doing managing. And there is another case, if we have time. We have time? Do we have time? It's already 5:15. There is another subluxated cataract with zonular deficiency. As you can see, this is even larger. This is a kind of huge defect, and I'll just let us bring it to the okay. Why is it not working? Sorry, what has happened? I don't know. It was working fine. Suddenly it has stopped. या कहाँ से चल रही है? फास्ट फॉरवर्ड कर दे के लास्ट का मुझे 1 मिनट दिखाना है. कहाँ से दिखा सकता हूँ? ऑप्शन नहीं आ रहा. I think it is a video of about 4-5 minutes, but whatever. So as you can see, this is the end of this. You see there are 2 Sioni ring segments which are sitting here. They are already sutured. The IOL is sutured, and since this so you can put 2 Sioni rings to stabilize the bag, and there is no problem in doing more than 1 Sioni ring to stabilize. There is absolutely no problem in that. And then after that, since this is a traumatic case, so I will probably put a iris implant in the bag, so which can kind of take care of the. So this is there are 2 iris implants we have to put, because one iris implant will leave, spaces in between. So they have to be going inside the capsular bag. And once I have put the first one inside the bag, unfortunately I cannot fast forward it, so second iris implant goes. They are actually 2 segments of iris implants available from Morcher. I don't know whether they are available in India by any Indian company like, but I think IOCare can make it now, because they are making customized, requirement. As per your requirement, they can manufacture and give it to you. So these are iris implants, 2 of them, and then you can put one over the other in a manner so that their gaps are covered. And once these gaps are covered, they are inside both of the IOL and the iris implant, everything is inside the bag. So bag has sufficient capacity, since the crystalline lens, what happened? So that can be done. I am sorry for whatever glitch there is in this video. Sorry for that, but you can do it, I am sure, and I did it and worked wonderfully well. Thank you.
Thank you very much. Thank you very much, Dr. Bharati sir, and for the wonderful cases you have shown of the subluxated cataract. And thank you everyone, all the speakers and the audience over here. Thank you very much.